Thank you, Becca, and thank you, Rasha. So I want to give you all a little bit of background as to how this came about. And as I begin this discussion, can I just see a show of hands for physicians in the room? Okay, why aren't you? Never mind. It turns out that the American Board of Internal Medicine Foundation launched an initiative with Consumer Reports, the channel to the public. And it is the Choosing Wisely campaign. Well, how did this come about? Why did this come about? It came about by organizing 9 different subspecialties, and I've circled mine right there in the middle. The American College of Radiology participated in order to come up with some basic rulemaking, if you will, around stewardship of resources in medicine. And so the input was not just a bunch of internists or the Consumer Reports folks looking out for the public. If you'll notice, this encompassed the combined wisdom, we hope, of 374,000 physicians from many different specialties. And here's why it came about. This is a way too busy slide. And that was their point exactly. These are, according to the American Board of Internal Medicine Foundation, 37 clinical situations in practice, in medicine, in which a test does not reflect high-value care. 19 out of the 37 referred to imaging. Now that points to a need. And the need arises out of the fact that 40% of patients in a visit to their physician have that visit predicated on either ordering an imaging test, reviewing an imaging test with a patient, or using an imaging test to treat a patient. So imaging clearly plays a big role, but it should only be playing an appropriate role and not making the hit list of 19 out of 37 lack of value entities. And the goal in building the appropriateness criteria for imaging was so that we would do the right exams for the right reasons in the right way. So these appropriateness criteria are generated by one of the committees under my Commission of Quality and Safety at the American College of Radiology. They are evidence-based guidelines with the strength of evidence noted up front, the level of evidence, to bring the user to the most appropriate imaging or treatment decision that there is for that specific clinical condition. The goal, you're going to hear pieces of the triple aim again, to enhance the quality of care and the efficacious use of imaging. Over 80 physicians from 20 societies are on the teams that generate these appropriateness criteria. The expert panels, listed here again, way too many to read, include surgeons, include pediatricians, include internists, include subspecialties of medicine, subspecialties of surgery. The process is very structured and, as I said, evidence-based. Many decades, tens of thousands of hours of volunteer work by radiologists and physicians in the clinical arena from almost every specialty society have come to generate 215 topics and well over 1,000 variants of the different conditions as of May 2016. These guidelines, again, should be able to allow providers to reach the appropriate imaging or treatment decision. And the various topics, I saw someone sort of questioning, what, only 215 topics? But the topics are very broad. So diagnostic imaging, there we see things like chest pain, headache, low back pain, interventional procedures for abdominal aortic aneurysms or spinal compression fractures, and radiation oncology topics like bone metastasis from cancers in other locations, or thyroid cancer. And just not to bore you with the process, but before a condition surfaces as something that needs attention, these are the factors that we consider. Is it at all common, this scenario? So the frequency of the condition, the economic importance of the condition, how many Medicare dollars are being spent, and for what outcomes? Are outcomes being improved? Also, the number of high-quality studies, back to evidence basis here, validating conclusions. And have we enough of the clinical variations on the theme? So, hearing loss. What kind of hearing loss is it? Is it conductive hearing loss? Or is it sensory neural hearing loss? These are different forks in the pathway. And because of the broad scope of data that you can imagine is involved, a tool, FACR Select, a product, was developed, and the nice thing about this product is to the ordering provider, and remember, not only physicians place orders, nurse practitioners, physician assistants, and to the ordering provider, this tool will give them immediate feedback, like a little buzzer going off, blah, wrong test, or there could be a better test. So you get a score back, and you also get a little PS, by the way. Other studies might be more appropriate here. The tool is based on national standards for best practice. So not just a pocket of expertise here, or this is the way it's done in New York, but rather a broad base of accepted guidelines. And here's the gem, integratable into EMRs of various forms, certainly the ones with the largest market shares. Well, let's look at the results of this kind of a tool. And what you see before you is the percentage of red lights. That would be the wrong test, bad idea, think of something else. The number of yellow lights, well, this isn't a bad idea, but you might consider doing a study without radiation first, like an ultrasound, or a green light. Bingo, perfect exam, fits the indication, go for it. And so those are the color codes. And what you see along the x-axis is over time. This is the practical history of putting this tool to use. And what you see over time is an overall decrease in the use of red orders and a simultaneous increase in the green lights as clinical decision support is incorporated into practice. So, what's the message here? You're teaching the provider at the same time. Yes, we all went to medical school or other training to be ordering practitioners. But technology changes. That's why matter matters, right? technology changes, disease states change, interventions for diseases change, and so the appropriateness of various modalities may also change. Well, here's the challenge: getting the evidence put into use by these providers. Thankfully, we have computerized order entry systems and EMRs that can seamlessly incorporate this kind of a tool, giving us the opportunity to put it into the regular workflow. You don't have to stop working at the computer, go look up something, and then come back. Everything is integrated with feedback and references. Here's why that CAT scan wasn't such a great idea. Radiation involved, and ultrasound has an equal sensitivity, or whatever the message might be. And you can go read about it. And all of the nuts and bolts, the whole cyberspace behind it, the whole practical implementation behind it, has thankfully been adopted by external third parties, the National Decision Support Company. So this is not just something made in someone's easy bake oven and it's a flash in the pan and good luck keeping up. All of that is handled externally. Here's why it really matters. 2 pieces of legislation recently passed, the Protecting Access to Medicare Act and then the MACRA legislation, both of which I'll explain very briefly, really are predicated on stewardship of resources. That would be the Protecting Access to Medicare Act, and demonstrating value into the equation of healthcare. I've covered the fact that this is really prime time for IT, the clinical decision support being fully integratable. It'll affect the quality of care, enhancing outcomes, avoiding errors or adverse events. How about the pop-up that says, MRI not a good idea in this patient with a cardiac pacemaker? There's a life saved. Reducing cost. IHA can applaud there, please. And boosting patient satisfaction. You're not just saying to a patient, you're not getting this test. You're saying, you know what, I'm going to get a different test for you that's better. I know your next door neighbor had this one, but guess what? In your case, because of your fever, it's more likely infection, so you're going to need a scan with contrast. Well, here is the PAMA legislation that was passed in 2014, 60 to 35. And what this did was require physicians, it was to have started January 1st of next year. The implementation has been delayed by what we think will be 1 year. So look for it in January 2018, and CMS is going to let us know when. At the last minute in November. Okay, thank you. But it says that physicians have to consult a government-approved, evidence-based, appropriate use criteria before ordering advanced imaging. So they're not talking about a chest x-ray or sinus films. They're talking about CT scans, MRI scans, nuclear medicine studies, including especially PET scans. So before ordering advanced imaging on a Medicare beneficiary, the goal of reducing cost in the triple aim, you have to consult a clinical decision support system. Now, your hands aren't chained. You don't have to follow what the decision support system advises you, but ever hear the phrase, I'm from the government and I'm here to help you? They're going to track your performance. Dr. Jones consistently consults but abandons the recommendation, and down the road, perhaps there will be penalties attached because it's not best practice. Not based on opinion, evidence-based, outcomes-based, stewardship of radiation-based. The next legislation came about in 2015. This put to rest the long-standing formula for Medicare reimbursement and said, you know what, we're going to start tying reimbursement to value. The value equation is going to take center stage, and the patient is going to take center place on that center stage. What have you done for the patient lately in terms of demonstrable value? And Becca alluded to this because look at the 4 components. Becca mentioned quality reporting systems and registries, and she's put it into a Steps Forward module as a usable tool to enhance the practicability of medicine, because the 4 components of demonstrating value are going to be show us quality, pay attention to cost, use technology appropriately, and improve practice. Registries accomplish many of those. Again, it will begin, we think, in January of 2019, and compliance with the quality reporting will be looked at beginning in 2017. Because in 2019, they don't know what you're doing unless they look at some prior years of performance. So the time to pay attention is right now. Clinical guidelines, condition specific. It's not just asthma. It's asthma with an allergy to X, Y, and Z. Or it's asthma with fungal sinusitis, part of a well-known clinical entity. Focused patient data reports and summaries available for all of the quality reporting that is going to need to be done, and a huge amount of support in terms of relevant information being given to you. Here's why that wasn't such a great idea. Or here's a study that shows that ultrasound is just as good. You might have missed it. I won't tell you the number of unwrapped journals I have at home. I'm sure to have missed a few of those studies. So, the clinical decision support system rates imaging exams as they're being ordered, as we've said. You'll get a green light, as you see, if it's the appropriate exam. And everyone see those little yellow circles with the radiation sign to the bottom right of the screen? It's an indicator of exactly, relatively speaking, how much radiation is associated with the study you've chosen. So this is a CAT scan, so you see 3 of those little symbols. If instead this had been an ultrasound, there would be none for radiation. Just to keep people apprised. Oh, I never knew that this patient would lose their hair after having 5 CT scans or 5 cerebral angiograms. And the nice thing about it is that same platform can be integrated into education modules for medical students, so that this is what they're learning. They don't have to adjust behavior down the road. And that's one of the applications. Another application is education for all takers in medicine, no matter where you are in the continuum. And it's this piece that is integrated into the Steps Forward module. And so this describes our scan. And what it is a program free for enrollment by radiologists, referring practitioners, PAs, physicians, and it provides a step-by-step guide. It takes you through 11 choosing wisely recommendations, and the goal is to improve the imaging appropriateness. and to get people familiarized with this decision support technology. Ultimately, to reduce unnecessary exams, sometimes duplicated exams, sometimes it's a good idea but there's a better exam. It's not that it's not necessary, but you've made the wrong choice here. Well, this is where the AMA and the ACR comes together. Each of us having been awarded a grant by the Centers for Medicare and Medicaid Innovation. The grant is under the umbrella of Transforming Clinical Practice Initiatives, and we are both support and alignment networks under that program. So a collaboration was a very natural thing to expect and a wonderful thing to experience, the biggest beneficiaries being our patients. The release was just late summer for this particular module. We're proud to be in that program and thank the AMA for the ability to reach such a wide audience through their module Steps Forward system. So, how is this particular module going to help me in my imaging ordering? Well, 5 steps, as Becca mentioned. First of all, to familiarize yourself with the whole concept of clinical decision support. Probably a good idea for physicians to do before that PAMA legislation really is implemented on January 1st, 2018. Probably a necessary step, might as well get to it. And to learn its role in optimizing patient care. Then just focus on one imaging area at a time to improve. Maybe you see a lot of chest pain as a physician in internal medicine. Maybe you see a lot of patients complaining of what the patient thinks is sinusitis as a practicing otorhinolaryngologist. Pick an area to improve. And prepare your practice. Downloadable tools, free access on the internet if you don't go through the ACR Select product. Prepare your practice with these tools. Bringing your practice up to speed. And actively discuss the appropriateness with the patients, not just, no, you're not getting that test. You know why I didn't order a CAT scan? I didn't order it because of the amount of radiation, and it's shown that in first-time sinusitis, that imaging may not be necessary. If you come back with sinusitis 2, 3, and 4 times, you might have an anatomical, structural basis for why your sinuses don't drain as well as someone else's, and we'll explore that then with a CAT scan. Give patients a reason, and they'll smile when you say no. So you discuss with patients with the tools in hand. Oh, you're very capable of downloading information from the internet. That's how you found me and the fact that I went to Columbia Medical School and blah, 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 right? You give them the tools. Here's the article that talks about it. And then you work with the electronic health record teams to get this seamlessly integrated into the various systems. So, at the end of today's activity, we hope that you would be able to describe the importance of clinical decision support and how to implement these tools freely available into practice, that you'd be able to pick an imaging area to improve or to suggest to your physicians to do so, and how to work with this through your IT teams, putting it into your order entry systems and EHR. So, we are going to have a hands-on session until noon. There are going to be 3 tables with ACR Select demos using different clinical scenarios. Mr. Jones has back pain, it's the first time, he has no neurodeficit, what would you do? And you get to play ordering provider and learn what the right thing is to do for Mr. Jones with back pain and no weakness and no sensory deficit. I'm not giving you the answer. There'll be a table for the AMA Steps Forward modules, and there'll be a fifth table for the IHA programs. So let the games begin. Yes, question?
Actually, we have time for a couple questions. And if you want, Michelle could come up and we could maybe do a couple of the scenarios as a group together. So people, if there's interest, people want to see them.
Okay, we can do that. He knew that my next slide said questions. And so shall we move over to a couple of the scenarios here?